Hi, everyone. Good afternoon. Welcome to the third part of a series, a workshop series on which we've entitled, How Do We Know When We've Achieved Health Equity? Just as a reminder, my name is Andrew Anderson. I'm an assistant professor in the Department of Health Policy and Management at the Tulane School of Public Health and Tropical Medicine. And I'm also an associate director for Partners for Advancing Health Equity, which is a Robert Wood Johnson Foundation funded program. And I hope you all have read up on us, or at least gone to our website at P4HE .org and seen are actually members. So I'm going to jump right into this session. I'm going to give you, here we are. So the goals for part three. First, I'm going to give you a recap of part one and two, because I know some of you may not have been able to join either one of those sessions. Those of you who have probably would want just a kind of a summary of those conversations that we've had leading up to this conversation. The last two sessions have primarily focused on the kind of describing some issues around measurement and evaluation of programs and research in health equity. And we started a discussion in session two, which focused on the types of interventions or policy interventions that might be useful for addressing some of the common health equity issues that we discuss in the field. This session is primarily going to be driven by you all. So in discussion groups, small group discussions, we're going to be talking more about the definition of health equity and how it serves us in terms of allows us to be measuring the same things. We're also going to talk about some of the challenges to measurement in your own work and the types of data that we need for measuring health inequities. In a lot of instances, we are focused on, we use the data that we have available, but it's not always the ideal. And so some of this discussion is going to focus on what are some of the data sets that we actually need to do this work. And then lastly, we're going to talk about the differences between health equity interventions or interventions to address health inequities versus interventions that are intended to address health disparities, and speak a little bit about the differences between health disparities and health inequities. All of these conversations are serving to better understand how we move in kind of unison when trying to understand progress towards achieving health equity. Even though sometimes I know in the last few sessions I've said that the achievement of health equity is it's more of a North Star, because even when we get closer to health equity, we still have to maintain it. So I'm going to jump right into the recap. So I presented this started to present this in session one and session two, because I think it's good just history as to how these terms have evolved and what we're referring to. So the term health inequalities was primarily used by academics and advocates in the 20th century. It's mostly used in the context of differences along socioeconomic lines. It's also been used to define differences in health outcomes across individuals, regardless of group membership. So it's more general. A lot of work done in the UK and in other parts of the world using this term health inequalities. We still use it today, but this is what the specific definition is. When it comes to health disparities, this has been also used very commonly. The focus here is on preventable differences experienced by historically marginalized groups. And you'll see right away that the difference between health inequalities and disparities hangs on that emphasis on preventable and on group membership. We have a little bit more agreement on the latter more than the former. Now, health equity, this is a term that has also been used for decades, but it's been the term that's been more often used in the last 5 or so years. It deviates further and potentially expands the focus from just socially disadvantaged people alone to all people. it introduces a more concepts of fairness and justice. And commonly, justice is more about what we deserve individually, and fairness is about the way we're treated in comparison to others. And so all of these terms, when we think about preventable, what exactly do we mean? How do we measure it? When we think about justice and fairness, how do we measure these things so we understand whether or not we're moving toward that state? Also, a part of session 2, we talked about the basic components of a health equity measure. And so the first is, this is a framework that was introduced by Paula Braveman in 2006 in her paper, I think it was in AJPH. So first, we need some sort of indicator of health or modifiable determinant of health, such as healthcare, living conditions, or the policies that shape them. And we talked about a variety of types of health indicators, self-reported health status, all of the clinical quality measures that we're used to working with. The second component, which is really what differentiates it from any typical health measure, is an indicator of social position. So we need different ways of categorizing people, and this is along social strata, social hierarchy, which is present, right, or studied more often in like sociology and some other fields. In this way, it differentiates from some of common measures of social determinants of health, where, so for instance, one of the examples that I gave last time was that comparing people who are socially isolated versus those that are not, even though social isolation is a social determinant of health, doesn't necessarily capture some sort of health inequity. Now, the third component is then some sort of measure for comparing those health indicators across different social strata. And we talked a bit about things like rate ratios, things that you're likely to see in public health statistics. And we talked about how these depending on how the type of method that you choose for comparison, that will influence whether or not you see a disparity to begin with, and whether or not those disparities are comparable or consistent over time. And then lastly, and actually today what we're going to focus more on is the second bucket, which is the indicator of social position and how that relates to the reference groups that we choose for comparisons when we're trying to evaluate whether or not inequity or a disparity exists. And let me just check. Oh, great. I'm seeing all the introductions in the chat. Thanks everybody for introducing yourself there. Then the last piece, we've talked about different justice typologies. So more often than not, we're focused on distributive justice when we're talking about health inequities, when we're talking about the solutions. So it's more about, it's based on this a principle of similarity. So people who are in similar positions should be treated the same. And this is where concepts of need, so the degree to which persons on groups are similar on different, similar in certain characteristics, they have varying needs for what needs to be distributed. And so this concept of distributed justice is what we usually speak about. There's also procedural justice, which actually talks about the process by which those resources are distributed. That's less often a topic of discussion. It's more so assumed if we can agree on what items deserve and who's deserving and what and deserving of what, then the rest of it kind of falls into place. But the process is very much a component of moving towards health equity, and we gave some examples of that. Some less often discussed is about retributive justice, which is about punishment for wrongdoing. And then restorative justice is about restoring relationships or conditions prior to an injustice, which in many of the cases where we're talking about historic injustice, this is not it's not possible per se, right? But there can be some forms of atonement and some forms of restitution. the key takeaways from the last two sessions have been, first is that the progress towards achieving health equity should be measured both as a process and an outcome. So when we're having these discussions, we'd want to understand, we can talk about what the desired outcome is, but the process and how we get there is key. The next is the choice of health measure, the groupings, the reference groups, whether we're measuring in absolute versus relative values. All of those are really important for how we define progress towards achieving equity. And it's important that as a community of evaluators, researchers, advocates, that we have some level of consensus on what these are, but there will likely be a plurality of measurement approaches. And it's just important that we're clear about the approaches that we're using and why. And then lastly, measuring and describing disparities in outcomes are still essential to assessing progress towards health equity, right? So it's not an either or, it's not that, and this is me introduced, feel free to maybe push back on this in the, when we open this up for a larger discussion, but it's not just, oh, we're moving towards measuring health inequities now, and we're gonna just move where we no longer care about health disparities, and that's kind of out of the way. And we'll talk a bit about the differences between those two approaches once we get to discussion. Okay, let me just check the chat really quick. Okay, great, introductions, hi everyone. Okay, so as I said, this session and the last few sessions have been me mostly talking about the different concepts and some of the challenges and tensions that we have in measurement. This session is going to be more interactive, and I'm going to be trying to get feedback from you and what are you experiencing in your own work? What are the challenges that you're seeking to overcome? Some of these issues we can talk through in our small groups. So if you could, we're going to be using menti.com, and there are two ways to access it. You could use your phone, where you can just use the barcode, so you could open your camera and just hover it over the QR code here, and then it'll automatically pull it up. Or you can go to menti.com and just enter the code on the screen. And so the code is 3151745 at menti.com. It looks like we have about 9 people that have signed in so far. So I'm going to give everyone a couple minutes or a minute to go in. I know some of you may not have used this before, so, oh yeah, thanks for Riley for dropping that in the chat. Okay, so we're going to start with a starter question, and this is also to help, familiarize yourself with this platform. Okay, good, 13, as more of you roll in. So this is a word cloud. So this will just, hopefully you'll see this pop up on your screen if you're using it on the computer or on your phone. The question is, what is one word that describes equity, or that you consider synonymous with equity? And I think you have up to 3 different submissions. Okay. Awesome. Fairness, justice, opportunity, equal, language. Okay. Great, people are getting the hang of it. Even though we're not going to be using another word cloud, but at least you get a sense of the interface. We're going to have a couple polls. Attainable, choice, deliberate. The access, more opportunities, democracy. I like attainable. I think that's a lot of people, there still needs to be just kind of an argument for it being attainable. I know in some of the earlier conversations about health inequities, people do feel as though it's just kind of a intractable problem. Needs-based, right? fairness and justice. I'm glad it looks like justice and opportunity, and multiple people have submitted that. Okay, great. And it looks like we have 20 folks now signed in, so that's great. All right, so I think hopefully you'll get the hang of this. If you have any questions, feel free to drop it into the chat if you're having trouble with Menti, and we'll address it there. Okay. Thank you. All right. So as I said, we're going to move through some of the major components of the last two sessions and focus on more of the discussion and trying to get to some consensus here. So the first thing is coming back to this definition of health equity. And I want to talk about how it serves our goals of understanding progress. So the most common definition that's advanced for health equity is that it means that everyone has a fair and just opportunity to be as healthy as possible. So the Centers for Medicare and Medicaid Services has a slightly different definition that's a little bit more, I guess they expound a bit more on like who they're speaking about. The Robert Wood Johnson Foundation uses this definition. There are a lot of different definitions of health equity, but they all have similar kind of boundaries and similar language. So the question for today is this measurable? Is it clear that we'll know when the goal has been achieved? And I recognize that this question is broad, so we'd need to be talking about health inequity or health equity in relation to what? So say if we were talking about maternal mortality, if we wanted to know whether or not we've achieved or we're making progress in achieving health equity and maternal mortality rates on a specific dimension. So we could be thinking about it along racial lines, as it's very popular. It's topical right now in the news because Black women have much higher maternal mortality rates. We could also look at it along other social position lines like poverty or sexuality, sexual orientation, and gender. We could look at it along religion, right? So there's a lot of, in certain societies, right, where certain people who are members of certain groups are treated differently than others. So, so the question is it measurable? Does it allow us to come up with indicators of progress, which is really dependent on that first question. So, okay. So first, a poll to the group. Is our definition of health equity measurable? So that everyone has a fair and just opportunity to live a life that is healthy, right? And so slowly, I think you might need to advance on your screen and Menti to be able to vote. And as a reminder, at least the definition that I'm proposing for fairness, right, is that fairness is about how you're treated in reference to others, and then justice is more about what you deserve. They're obviously related terms, but there's a reason why they've been separated as well, at least in the definitions that have been proposed that include both terms. Okay, so we have kind of and now this is really interesting to me. I'm excited to see this split here, that there are certainly more people who think no, slightly more that it's almost equal across the board. So this is good kind of fodder for discussion here. And I don't think, and maybe this is where we can talk about this in the small groups. Okay, so we have just about everybody who's voted. So this is just kind of to get your initial reactions. Is to what extent, if any, could this definition be improved to serve the needs of measurement? And so the reason why I'm asking this question before we move into small groups to discuss it is just to get a sense, a temperature check in the room, if there's some flaws that you see in this definition, or if there are really great strengths in this definition that help us, for those of you who voted yes. For those of you who don't know, then that's something that we can chat about in the small groups. Let's see, there's also a chat. Okay, so we have one answer so far. So define opportunity. So That's true, right? I think one of the things that a lot of people agree that equal opportunity is a, or is a way toward a more fair society, right? But what exactly does equal opportunity mean, or what exactly does opportunity mean generally? Is it just opportunity in participating in the market? Is it opportunity to being a fully participating member socially, right? So you could have access to, labor market, but then, be ostracized in other ways. What are the comparison groups, right? So this is another interesting question, right? It doesn't necessarily specify particular types of fairness and injustice, or the groups that are being, it doesn't say anything about whether or not we should focus on disadvantaged groups even. It's pretty much, it's everyone. We need more specifics about what it means to be fair and just, how do we define this, right? So I propose that kind of brief definition, but it's not very clear still. Agree with operalization of, how can I not say that word right now, of the comment above. Identifying goals to be achieved in that process, I agree. I don't think it needs to be improved, but I think health equity is measured based on individual groups and is ongoing. So metrical measurement is difficult, okay? So we could say that, from the outset, we could note that there's some limitations to the way that we do measurement generally in order to know whether or not is this bean counting, or are there other ways of understanding progress. Identifying goals to be achieved in that process, agreed. A definition, broad, but we need to better data sources and individual experiences. Good point. We're going to get to that in the second discussion. Need an established baseline of fair and opportunity to made less just subjective, which I'm sure can be done. Agreed. I think that's, again, difficult to figure out what that baseline is and for which groups are we talking about. Now, what about qualitative measures such as awareness of that definition in healthcare? Okay, right. I'm very interested in anything that anyone has to recommend about the ways that we could move away from just simply the quantitative measures that we often think about when looking at differences between groups. Who is a comparison groups? Is there a comparison group? Agreed. Okay, so I'm glad the multiple people are saying, are mentioning these different comparison groups, and this is why I wanted to focus a part of this discussion on the reference groups for measurement, right? Because even if we're not using quantitative measures, we still need kind of a benchmark or benchmarks of comparison. So many populations of interest, but we need to start somewhere. I agree. Okay. So, and I was actually going to bring this, I couldn't pull this in time. The Cochrane, maybe you can Google this, the Cochrane Collaborative has done some systematic reviews and meta-analyses on interventions that are designed to address social determinants of health and disparities. And they have a kind of framework called Progress Plus, which defines the different social identities that health tends to differ based on. So one of them is, of course, like race, ethnicity, and culture and language, sexual orientation and gender identities, but they also include things like place of origin, like the actual place where you live. It's a more global framework. It also talks about, obviously, socioeconomic differences. It also talks about religion. And then the plus stands for some of the kind of other dimensions that may be layered onto those identities that are more circumstance versus identity based. So anyway, I can share that in the chat. So the group discussion, so in 15 minutes, I'd like us all to break out just to work on this one question. So in your work, what are the greatest challenges and or opportunities to measuring health equity? And so what we're going to do is randomly assign you to different breakout rooms. I think we have 3 of them. So they're going to be very small group discussions. You can choose to jump. I don't think you'll need to jump to another room, but you'll just need to press join room. And in the beginning, maybe you all want to just briefly introduce yourselves. We'll be moving from room to room just to listen in on the conversations, maybe join in here and there. And then after we have the small group discussion in the 15 minutes, one of you, if you could select someone in your small group to just kind of summarize what you discussed, and then we'll continue on, and then we're going to have a couple of these. So yeah, I hope this is informative. So I look forward to hearing your conversations. So I think you should have seen a breakout room window pop up, and now you should be able to just, you'll either be randomly assigned or you can click join to one of these 3 rooms. All right, so we'll be back in 15 minutes. Hi, everyone. Thanks for that discussion. I was hopping around and I heard some really great points being made. Does anybody want to share a little bit about some of the discussion that you all had, maybe naming 1 or 2 challenges or opportunities in your own work? And I recognize some of you may not have gotten around to designating a person to report out, which is fine.
We didn't designate anybody, but I'll jump in.
Yeah.
So a couple of things that resonate with the group. I think one is that, many of us still find challenges in being able to sort of be statistically valid because our populations are small. And, we're combining multiple years of data. And so we're missing, potentially nuance in order to be statistically sound. So that continues to be a problem with measurement on a technical standpoint. And then on a larger scale standpoint, we also talked a lot about how, for a lot of the work that's being done to improve health equity, it's still really early. And so we need more time to understand what those impacts are. And so while we may want to be measuring now, and we may be even seeing changes, it's hard to attribute those to system level changes because it's still early.
Right. No, those are some really good points. Oh, Angela?
Hi, yes. So I would like to follow up on that because our group kind of talked about the challenges in terms of time and establishing, sorry, there's a huge thunderstorm outside right now. Challenges with leadership support in gathering the right kinds of data and measurements, and how it's helpful to have EDI in the strategic plans, which is beginning to happen more often. And then we talked about specific challenges in reaching rural populations and some examples of how that
Oop, I think we may have lost your connection there, Angela. It's probably the thunderstorm. So maybe we can circle back, or you can drop the rest of your comments in the chat. But I do recognize that I think one of the themes that I'm hearing across these comments is it is time consuming, the buy-in that you have to have within an organization, the costs that are associated with collecting data, the difficulties in actually doing the data collection itself. I know I think I heard another group talking about the difficulties in actually then the actual analysis of those data. Oh yeah, I see. I'm in New Orleans as well. It hasn't started where I am yet, but I'm sure it's coming. Talva, do you have a comment?
Yeah, I was just going to jump in here and forward what Ms. Porter was saying. We weren't so much saying that it was time consuming as we know it is. It is quite, certainly with the data issues and all of that. The point that I was more so making is the time period. So this health equity work has only regained in earnest since the 60s now, over the last 2 years. 2 years is not enough time to accurately measure the work that so many people are doing. So we can measure it individually, like, oh, maybe this group is getting more Medicaid benefits, or this group is getting more access to this. We can individualize each group and measure it that way, but on a broad stroke, we can't measure, or at least certainly Louisiana Health Department hasn't figured out how to measure health equity movements on a large scale in a year and a half. And not even that, because we're only in 2023. We were all at home for most of 2020. So we're only looking at the end of 21 into 23 that some of these health equity departments even existed. So that's where we are in the sense of the time period in which to measure health equity. I personally don't think it has lapsed yet. I think we need maybe 10 years or a bit.
Yeah, that's a really good point. Something else that I've heard about, just even when it comes to funding of research, is the time period that grants allow, right? So if you have a grant that is intended to look to see whether or not an intervention leads to some improvement in health equity or reduction in health inequities, is a 5-year period or a 3-year period even enough? And most would say probably not, right? And even then, you might see short-term changes, but do we see long-term changes as a result of those? And that's what we're really interested in, right? We want to see long-term change. So, that's another important point. Okay, so just in the interest of time, we're going to keep moving forward to the next section. So as I mentioned, we wanted to talk a little bit about reference groups. And so we're going to go right back into our small groups to talk about the differences or the difficulties in choosing a proper reference group, or the considerations, I should say, that one would make when choosing a benchmark or comparison. And so if you recall from session 2, we talked a bit about the different approaches for choosing a reference group. So we could select a minimum or a standard below which health performance is judged to be inequitable. So that could be separate from any particular group, and all groups are judged according to that standard. We could also select a reference group value that's just the mean across all groups. Oh, I'm so sorry. Thank you. My screen is not shared. And then we could also choose the group with the highest or maximum observable health status. And so the way that this plays out in the real world is that last one, choosing the group with the maximum health status. Sometimes you'll see, say, the Asian population or the Latino population may have lower rates of premature death. So we'll pick the group with the lowest, and then compare all groups to that group. Or we might say across all groups, what is the average rate of premature death? And then we just compare everybody to that average. Or in the first instance, we'll just pick a different goal. And in this case, I have an example here. The Healthy People 2030 health equity goal is separate from what any particular group has already achieved. And so in this case, so this is a paper that we just came out with. This was published yesterday. We're trying to explain a figure explaining the difference between a health disparity and a health inequity. So it's, in health disparities, traditionally thinking about the difference between, often when it comes to racial and ethnic disparities, the white population and other racial and ethnic groups. But as you can see, if we choose that population, it may actually fall short of the definition of the highest level of health attainable in a particular population or in all populations. So setting another benchmark, like say the Healthy People 2030 health equity goal might be, or goal generally, might be another approach for measurement. There are arguments against and for this. And so a part of what I want to discuss next in our small groups is, what are some of the limitations of these different approaches, or is there general agreement among maybe your small groups of what the right approach should be? There's, like I said, there's a lot of different ways to do this, but which approach gets us closer to the goals of that's set out by that definition of health equity, right? And even in this example, sorry, that I just provided, it is still a oh, sorry, just looking at the chat. It is still that healthy people 2030 goal is still somewhat arbitrary, right? So we could expect better health for the nation than this, but this is what a group of people came together and had it, came to consensus on a reasonable goal for 2030. Okay, so in our small groups, so we're going to go back to our same groups, and for 10 minutes, we're just going to briefly discuss what are the advantages and different disadvantages of these choices, and are there others? Just the you can start by thinking about those 3 different choices that I mentioned, or you can think of some others. Would love to hear your thoughts. Okay, so looks like most of us are back from the breakout rooms. So the prompt was essentially, what are the pros and cons of different approaches to selecting a reference group from which to benchmark progress? As you can see, this is really challenging, but it is also a really important decision, right? And I think through some of the discussions that I've heard, it's more about, as I was saying in the beginning, there might be various approaches, but there has to be consideration around why that specific approach was chosen. It's probably not going to be a one size fits all, but I'd love to hear any thoughts that you all had that came up in your discussions about these challenges and selecting one. I didn't expect you to say, all right, this is the one that we're going to go with. This is the right one. But maybe even if there were other approaches that, I didn't mention it on these 3. All thoughts are welcome. And you can also drop them in the chat. No thoughts? That's okay too. I know this is a pretty heavy question and a little technical, but I hope at least this type of discussion is a starting point to start thinking about some of the considerations that you might have in your own work. I think in the remaining 10 minutes that we have, I wanted to just talk a little bit and maybe open the room up. More coming back to this question about what are ways that you, oh yes, it will also need to reshare my screen. Well, in this case, actually, I'm going to stop sharing for a moment. So this is just a general question for the group, because one of the goals of this session is we'd like to continue having these conversations and produce some sort of maybe guidance documents in the future. It might guide future sub-projects within P4HE to try to come to some level of consensus on these topics. We may also be hosting more detailed workshops about ways to think about this. All right, this has been pretty higher level, right? But I would love to hear from the group if you have any requests almost for types of information, types of research even that might be helpful. And I'm not thinking about even research in the clinical trial type study, but pulling of information together that might be useful for you in your own work. Going back to the question about some of the challenges and opportunities that you all face within doing this type of work. What type of information would be useful? Oh, Ellen asked a question. Sorry, I wasn't looking in chat. Would the reference point depend on what you want to measure to affect a particular outcome? Yes, so I think the reference group does matter. It depends on so in the beginning, I was talking about that second component of a health equity measure is that indicator of social position. So depending on the outcome that you're studying, depending on the type of inequity you're studying, the reference group will depend on that. But regardless of the type of group that you're studying, there's still going to be some measurement choices that might be consistent across populations. So that's why I presented these three different options for doing so. I think in some of your groups, you mentioned the most common way to do this historically has, or at least for racial and ethnic inequities or disparities, has been to compare all of the racial groups to the white population, with the assumption that that comparison is, if there is no difference, that means that maybe racism isn't operating to the same extent within that particular group, or there's been some intervention that has overcome the effects that has equalized a particular outcome between the white population and the Hispanic population, or some other. In research, we tend to think about this as like the residuals. So once we've kind of controlled for all of the other factors, and if we still see some sort of difference between the white population and the Black population, for instance, then we would say that, okay, there's still something going on here. It might be related to discrimination or some other barriers that are not accounted for by, say, education and income, language, zip code, some of the other predictors of health. So that is why the choice really matters. But given that we're moving toward this definition that we started with, which is broader than just a comparison between racial groups, that's why thinking about how we benchmark progress towards health equity, we need to really be thoughtful about what those new, potentially new benchmarks might be. And I think in one of the groups I was in, someone mentioned, even centering a certain population or centering them as advantaged, and then saying that that group, because they have that advantaged social position, should then be the group that from which all other comparisons are made. It doesn't necessarily also influence the, it's not necessarily that, and this is probably a broader discussion, that we're going to be conferring those same privileges to all the other groups in order for them to get to that, because those privileges may be undue, right? It may be based, the privilege may be based on the oppression of other people. So, but that's a kind of a separate conversation. But anyway, so that's why we have this conversation about reference groups. So I'm going to just move into the next steps. So now I'm going to share my screen. All right. I think everyone can see this. So some of our next virtual events we have coming up in June. We have a webinar called Building Partnerships for Health Equity Advocacy. And then we also have a workshop series on research synthesis for evidence-based health policy. So this is about teaching skills and how to synthesize and interpret large quantities of studies and other types of information that's been produced to try to assist us in this work. You can register for this webinar using the QR code here. And also for those of you who are just joining, who aren't already members of P4HE, please, sign up. We are also on all these other social media channels. But we didn't get to all of the discussion groups today because we had, there's a little bit more content. So, but we're going to be planning more of these in the future. And we're going to drill down more specifically on some of these topics because the hope is that we can start to move towards some consensus on these issues. But even just bringing up the difficulty, I think, is important in starting that conversation. And also, yes, there's also going to be a post-workshop survey. So if you could please fill that out and provide any feedback, that would be great. I think there's a link. Riley has dropped those links in the chat. But until next time, thank you for joining. This has been at least really helpful for me to help to think through some of these issues with all of you based on the type of work that you're doing in various sectors. Alrighty, thanks everyone.